So just to get us started, today we have a host of speakers who are going to be speaking and sharing with everyone to help us understand what policy systems and environmental changes are by giving actual case study examples from across the state of Massachusetts. Myself, my name is Aaliyah Martin. I am a Senior Community Health Associate here at Health Resources in Action, and I will be laying the foundation, giving definitions and a few national examples of policy systems and environmental changes. I will be followed by Kathleen McCabe, who is the Director of Policy and Practice here at Health Resources in Action, and she will be sharing about smoke-free housing. We are also joined today by Catherine Rattay. She's a Principal Planner and Manager at the Pioneer Valley Planning Commission, and she will be sharing with us about policy changes that can be made to the built environment to increase health in a community. And we will be closing with Arlene Goldstein, a program manager of the Blue Hills Community Health Alliance, or CHNA 20. She was formerly of Impact Quincy, and she will be sharing a policy change that has made great impact in the state of Massachusetts and has also been held up as a model for the entire country concerning opioid overdose prevention. So without further ado, I do want to start us off with a poll question. And this is really just to get us started to help us understand who's on this call, who's on this webinar, who's participating, and sort of what your needs are. So you should be seeing a poll question on your screen. And at this point, you should be able to answer the poll question of how familiar are you with policy, systems, and environmental changes. And you can choose that you are very familiar, somewhat familiar, or not at all familiar. So if folks just want to take a few seconds to go ahead and choose your answer, then we will be able to actually share the results live with the entire audience. So I see that some folks have answered, and some folks are still answering. I'm going to give folks another couple of seconds just to get their answers in. And so I'm going to close the poll now so that we can share the results. And on your screen, you should be able to see the results. And so it looks like most folks are somewhat familiar, and very few folks are not at all familiar. So that's great. We've got a mixed audience of folks who are at least somewhat familiar with policy systems and environmental changes. So we're just going to go ahead and get started. What exactly is a policy change? This is really looking at laws, ordinances, resolutions, mandates, rules that can be either formal or informal that will have an impact at the policy level. An example of this could be an organizational policy that actually provides time off during work hours for physical activity. Systems changes are very similar, but instead of impacting just a policy, this is impacting a system. So it's looking at an organization, an institution, a system such as a school system, a transportation system, a park and recreation system. Those are all systems that would be impacted by the change. So another example of a systems change could be changes to a school lunch program where salad bars are instituted or vending machines that have unhealthy foods are actually removed from the system or from the school itself. An environmental change involves actually involves a physical or material change to a specific environment. This can be a social environment, an economic environment, or a physical environment. Why don't you go ahead? So I apologize for the technical difficulties. I know that some folks are unable to see the screen at the moment, but please listen carefully, and I'm really just defining policy systems and environmental change. So I was talking about environmental changes that they involve changes to a physical environment, and an example of this could be incorporating sidewalks, bike paths into actual community design to change the physical environment to allow it to be more healthy. One thing that's important to think about is really why is it important to focus on policy and systems change rather than only programs. One of the important pieces of that are because of the greatest impact that it can actually have on a community. So as we see here, some of you may be able to see this. This is the health impact pyramid. And on this pyramid, at the very bottom are socioeconomic factors, and just above that is changing the context. When we focus on changing the context or on socioeconomic factors, that will actually have the largest impact on the health of a community. Oftentimes in the past, we focused a lot on specific programs, which might include counseling, education, or a specific clinical intervention. And these are great, but they don't have as much of an impact because not everyone will be involved in the education session. Not everyone will be involved in the clinical intervention, as not everyone goes to a doctor, whether it's because of access issues or issues of time or health insurance coverage. So these impacts are actually only reach a small segment of the population. But if we change a policy or a system or the environment in which we live, we'll actually be able to reach many more people in the population. So when we look or think just about programs, programs are often finite. They may only happen one time or a few times or just for a scheduled amount of time, so that they're short term. They're often difficult to sustain as they will need ongoing funding, which we know that funding streams and the funding environment changes a lot. They're often focused on individual behavior change and not necessarily changing the context in which we live to actually enable someone to make better behavioral choices for themselves and for their family. Policy systems and environmental changes, on the other hand, are often ongoing. They're often at the policy level, so once the policy is put in place, it's more difficult to change, enabling it to be long-term and also more sustainable over time. So an example that we see from schools. Schools often have many different programs to provide healthy snacks. They may participate in a walk-to-school day. Some states have walk-to-school days, and here in Massachusetts we do. There's also an international walk-to-school day. And some schools even provide health screenings either for the students or for the staff. But those are often one-off events that only happen a few times a year and aren't necessarily ongoing. If we look at PSE changes or policy systems and environmental changes, those can be more lasting. So instead of just having healthy snacks, there can be an actual policy in place to provide students and staff with healthy food and beverages, so that even if the administration changes, that policy will still be intact and established and implemented. Likewise, is having a safe routes to school program or a walking school bus where the students are able to walk to school on a daily basis also provides long-term sustainability, as well as establishing for the staff, instead of just health screenings, but establishing a wellness team where changes can be more lasting. And while we are talking today about policy systems and environmental changes and how they have a much broader impact and a longer-term impact than programs, it is a comprehensive approach, so that having only policy changes without any programs may not be as effective as having the combination. So if you're looking to focus on policy systems and environmental changes, it's actually going to take a lot more work than just necessarily doing one program, but may involve assessing what the current situation is. It may also involve community engagement, because you will need to have buy-in to actually create the change that you're seeking. It may actually even involve some education, some increasing in knowledge level and skill building of community members as well as coalitions. There may be programs that you might implement that may support the policy change going forward. And of course, once you have the change in place, you will definitely need to promote it and enforce it. Some of the catalysts or some of the reasons that policy and systems change happens is because there's compelling data. There could be an event that happens in the community where peers, residents in the community are calling for a more massive change than what has already been taking place. There could be funding that focuses on policy, systems, and environmental change, but often there is some sort of commitment from some entity to really dig in for the long term to actually create this change. One of the changes that we have seen nationally is that of seatbelt laws. At first, not every car was manufactured, even had seatbelts in them, but now it's very much the norm for cars to be manufactured with seatbelts. And at the same time, there are also laws put in place for child safety seats, so that both children under a certain age must be sitting in a child safety seat. And we've actually seen these changes happen over time. It wasn't an overnight success. In 1971, the federal government set minimum standards for child safety seats and restraints. And by 2006, in that year alone, 425 children under the age of 5 were saved because of the child safety restraints. And because of seatbelts, over 15,000 lives were saved for those who were over the age of 4 in 2006. And just in general, since 1975, society has saved over $5 billion in medical costs, lost productivity, and other injury-related economic costs. So you see this data has been collected since the 70s, and it's really a policy change that has had a lasting effect and an effect that we can monitor. And this data is national data, so this is data coming from across the entire country. So we've got one more poll question here just before we transition into our case studies. And this is just asking folks if you are actually currently implementing any policy, systems, or environmental change in your own community. So we've gone ahead and we've launched the poll there. It's just a simple yes or no. So folks are able to go ahead and vote. So I'm going to go ahead and close the poll to be able to share the results in just a few seconds. Some folks are still answering. So we can go ahead and see from the results that the vast majority, not the vast majority, but the majority of folks are actually implementing some sort of policy, system, and environmental change in their community. And so with that, we are going to go ahead and transition to Kathleen McCabe. As I said earlier, she's a Director of Policy and Practice here at Health Resources in Action. She brings both strategic leadership and technical content expertise to the policy and practice work. In her time here, she has been working on smoke-free housing and has led the best practice policy research in the areas of transportation, chronic disease prevention, climate change, and a whole host of other things. So without further ado, I'm going to turn it over to Kathleen.
Hi, everyone. As Aaliyah mentioned, I have been working here at HRA in the last several years. Actually, since 2009, I've been working on the issue of promoting smoke-free housing policies here in Massachusetts and also in Rhode Island and in El Paso, Texas, most recently. In partnership with my colleague Chris Sanson from the Public Health Advocacy Institute at Northeastern University's Law School, I provide technical assistance to housing and health organizations as they consider and implement smoke-free housing policies. So today I want to focus on providing you all with a little bit of background of the issue to give you some context, and then discussing our approach from a policy and systems perspective. I'm happy to answer questions during the Q&A, and then also available offline after the presentation to follow up with any more specific conversations that folks want to have. So just dig right in here, talk about why are we working on smoke-free housing. And quite simply, the most direct answer is that the U.S. Surgeon General came out with a report back in 2006 saying that there is no safe level of exposure to secondhand smoke. Secondhand smoke is a Class A carcinogen, meaning it causes cancer. And in thinking about multi-unit housing, by design, our buildings are built to maximize airflow, and that's generally done to improve air quality and reduce the likelihood of mold and moisture and other types of things growing in our buildings. But as a result, it means that if someone is smoking in their own apartment, the smoke is not contained to that specific unit. In fact, the American Society of Heating, Refrigerating, and Air Conditioning Engineers, which is the acronym is ASHRAE, they generally set the standards for air quality in buildings, and they have stated that ventilation and other mechanical changes to air in buildings is costly, but also rarely prevents smoke incursion. There's really not much you can do from a mechanical perspective to get secondhand smoke out of buildings, and the only effective way to eliminate exposure is to remove smoking from the buildings. In Massachusetts, how did we get here? Many of you that live in Massachusetts may remember that back in 2004 we had passed a smoke-free workplace law, which removed or prohibited smoking in workplaces, which included restaurants and bars. And at that time, the State Department of Public Health set up a hotline where you could call in and log a complaint saying, you know, I'm at TGI Fridays and someone is smoking here. And very quickly, our state and local health departments realized that there were very few violations of the workplace law, but they received a huge number of calls to that hotline and directly to local health departments complaining about smoke incursion in multi-unit housing. And we know that the home is where children are most exposed to smoke, and now since our workplace law went into effect, that's the place that the majority of adults are exposed. And so people are not exposed as they're going about their day, and then they come home and they can't breathe or are experiencing health problems at home. And my work really came out of that fundamental problem and beginning to understand and realize that we could do education about policy adoption directly to landlords. My work is funded by the Massachusetts Department of Public Health. So as I mentioned before, there's no safe level of exposure to secondhand smoke, and it causes severe health problems in both children and adults, people with compromised immune systems and people without, smokers and non-smokers. And the most recent Surgeon General's report, which was released in January of this year, really illustrates the damage that's caused to non-smokers by exposure to secondhand smoke, and that includes an increased risk of stroke by up to 30%, in addition to a whole host of cancers, heart disease, respiratory, and reproductive issues. So we're learning more and more about secondhand smoke. Not only, I think, the common knowledge is really around how bad tobacco is for smokers, and we're learning more and more about how bad it is for non-smokers as well. And along those same lines, since 1964, which is when the first U.S. Surgeon General's report on tobacco was released, 2.5 million non-smokers have died from diseases caused by exposure to secondhand smoke. For children whose bodies are still developing, the risk is really great too. Some of the health problems associated with secondhand smoke in children are middle ear infections, respiratory disease, chronic coughs and colds, sudden infant death syndrome, among other examples. And one study that I'd like to highlight while I'm talking about this issue was actually a study that was done here in Boston area, and it was published in the journal Pediatrics back in 2010. The researchers worked with two cohorts of families. One group was living in multi-unit housing and the other in single-family dwellings. The researchers took saliva samples from the children in both cohorts. Oh, and I'll mention that the families of all the families participating in the study had non-smoking homes. So nobody was smoking. The parents were making the decision to not expose their children to smoke in their home. So the saliva samples were taken, and the researchers were measuring for cotinine, which is a biomarker for exposure to nicotine. And what they found is that the children living in multi-unit housing had significantly higher levels of nicotine in their systems than the children living in single-family dwellings. And what that really illustrates is that just because of where they live, these children were at much greater risk for health problems down the road, and there was really nothing that their families could have done differently to protect them. So I want to just define smoke-free housing before I get too far into this. No smoking rules mean that there's no smoking, not no smokers. People who smoke still live in buildings that have smoke-free policies. They just go outside when they smoke. The policies include no smoking anywhere in buildings. That includes individual apartments. Many landlords are making their entire property smoke-free, while others designate a smoking area or a perimeter around the building. And in thinking about community, and Aaliyah was talking about the different types of places where policies and systems can be changed. In this example, we're really talking about the community as either the building itself or a group of buildings. In the case of public housing, a lot of times entire developments or an entire portfolio of one landlord will go smoke-free. We're not, in my example, talking about entire cities and towns, but the decision makers in this case, and I'll move on to the next slide, are the landlords. And so the way that we've approached this is what I call a voluntary approach, and that means that nobody is mandating that people are going smoke-free. My colleagues and I provide education and tools to building owners and management companies who are then making a decision to go smoke-free. Our information is really comprehensive. It includes health benefits, fire safety, cost savings, a whole host of reasons why people might choose to go smoke-free, and then landlords, the vast majority of the time, decide to adopt a smoke-free policy on their own. We recommend a process that is very inclusive of partners and residents and takes about a year to implement. But that said, since this isn't a regulation, it's a decision to include a policy in a lease. The landlords can sort of take our information and adapt it as they see fit. So they may not take a full year if they don't think that that's appropriate for their building. The reason that we have developed this process is because we feel like the policy will be most effective and people will comply with it most if there's buy-in from both decision makers and the residents who live there who have to comply with the rule. And so the process is designed to really encourage participation in the decision-making process from residents and other partners. There are examples from across the country of municipalities that are taking a different policy approach to this issue. And so, for example, in some towns in California, there has been legislation or law locally that prohibits secondhand smoke in some or all buildings, multi-unit buildings. Another example is in Maine and Oregon, and locally here in Massachusetts, the town of Amherst has a law which requires landlords to disclose whether or not they allow smoking to a prospective tenant. So there are other approaches. I'm focusing on ours. Here's a really brief overview of how folks go through the process of adopting a smoke-free rule. And we have tools embedded for each step of this process. I don't have time to get into any detail, but I just did want to highlight that resident engagement is a key part of the process. We include other partners like resident service coordinators, maintenance staff, home health aides, fire departments, hospitals and health centers, among others. And so the timeline for implementation of the process allows for maximum compliance because it allows for people to practice the behavior change of going outside. It allows people to seek resources to help them quit or modify their behavior if they're interested in doing that. And it also allows time to train all of the people who then enforce the policy down the road. So I mentioned before, smoke-free housings are a material part of a resident's lease, which means that it can be enforced. And as Aaliyah was describing the differences between programs and policies, I think in this case, an example of a program might be that a landlord would bring in a smoking cessation counselor, encourage people to move outside when they smoked, but not actually incorporate it into their lease, so there would be no enforcement mechanism. So while it's not the intent of the policy to evict, it certainly is possible to evict based solely on a violation of this policy. We are also working at a systems level to encourage smoke-free housing among all sorts of types of landlords. And here in Massachusetts, that has been, we're working with our Department of Housing and Community Development, which is sort of our state version of the federal HUD, Housing and Urban Development branch of our government, to encourage guidance, or to develop guidance, sorry, to encourage all public housing landlords to adopt smoke-free policies. And HUD has issued similar guidance nationally and also developed their own toolkit. So there are a whole host of smaller policy decisions that folks make when they're making the big decision to go smoke-free. They think about grandfathering, smoking areas, a timeline for implementation, e-cigarettes. And so within the big policy of smoke-free housing, there are a lot of other smaller decisions that landlords are making. I'm about to wrap up, but just want to do two quick other slides. So in terms of the impact that we've had, I think it's great, and it's on several different levels. They include reducing exposure to secondhand smoke, which is our primary goal. Sort of an added benefit, and not the primary goal, is that a lot of people end up making quit attempts as a result, mostly because it makes it a little bit more challenging to smoke for them. It's not as easy, and so it's a good time for people to try to quit. For the landlords, some of the added benefits, and also residents for sure, reducing risk and occurrence of fires caused by cigarettes, and lowering operating and turnover costs associated when a new resident moves in, or when a resident moves out and a new resident moves in. There are instances of reduced insurance premiums, increased physical activity among people living in buildings, as well as just sort of increasing the number of buildings to create a more positive and healthy social norm around tobacco. So I want to wrap up by showing you what we have done here in Massachusetts in public housing. We work across the market spectrum, but it is a lot easier to track. Oh, sorry. Okay, sorry. It's a lot easier to track the adoption of smoke-free policies in public housing than it is in non-public housing. So we are working across the market spectrum. In 2009, when I started working on this, there were no policies for, no comprehensive smoke-free housing policies in Massachusetts public housing. And since then, as you can see here, by the end of this year, we'll have almost 50 public housing authorities that have gone smoke-free, and we expect about 70 by the end of 2015 out of our 241 total. So we're seeing similar trends across the market in terms of other private subsidized housing, market rate buildings, and even condominiums. So there's a lot of momentum around this issue, and like I said, I'm happy to answer any questions, and that concludes my portion. Thank you.
Thank you so much, Kathleen. And as she was saying before, if you do have questions, please feel free to type them into the chat box. And we do have some time. Hopefully we'll have time left at the end of today's webinar to be able to answer your questions. And if we don't have that time, we will at least have a listing of the questions, and we'll be able to follow up with you afterwards. So webinars, we're often sitting in the same place for a long period of time. So I do want to encourage folks to just take a few minutes to stretch as we transition to our next speaker. So whatever you need to do, you can join this woman on our screen and do a quick stretch, to get the cramps out of your legs, to make sure the blood is still flowing. And with that, we will transition to our next speaker. Our next speaker is Catherine Rattay, who works as a principal planner and manager at the Pioneer Valley Planning Commission. As I said before, she works on a whole host of things, including work with sustainability and engaging citizens in regional sustainability planning, as well as the processes there. Catherine has expertise in participatory planning, food security, smart growth, climate change, sustainability, energy efficiency, adult education, training of trainers, and of course, transportation planning, especially bicycle and pedestrian planning. So without further ado, we are going to go ahead and allow Catherine Rattay to speak. So Catherine, take it away.
Thanks, Aaliyah. Greetings, everybody. It's a privilege to be with you all. I'm sorry I can't see you, and I hope I will be adding something useful to your day. The next slide, this is me. Oops. So Aaliyah already read my little introduction, but I'm from Massachusetts. I was born in Boston and raised in Amherst. The previous speaker called it Amherst. The funny thing about Amherst is the joke is that in Amherst only the H is silent. It is a very active community. I was out of the state for 20-plus years, and then I returned 16 years ago to work for the Pioneer Valley Planning Commission. I am trained as both a social worker and a city and regional planner, and I've done community development and organizing in a variety of settings, including as a Peace Corps volunteer in Cameroon, Central Africa, and I now live in Springfield. My job, as are the other presenters, is to help you all understand the difference between programs and policy systems and environmental change by presenting an example of policy systems and environmental change in the built environment. And I'm also charged with helping you to identify the leverage points, the places in your community or neighborhood, however you define your community, where you can most easily and most effectively make change. But first, I feel it is necessary to make sure that we all understand what the built environment is. I think it sounds kind of technical, but really it's not. The built environment is one of the determinants of our health and well-being. It's part of the global ecosystem, and along with the natural environment, human activities, the local economy, our relationships with family, friends, and neighbors, and our lifestyle, it determines our health and well-being. But again, it really is as simple as it sounds. The built environment is anything that is built. And it is a broad concept, but if your goal is to make your community healthier, it makes sense that you would focus at least some of your efforts on improving the built environment to promote health and well-being. So now that we agree that you want to change the built environment in your community, it is easy to understand that a focus on policy and/or systems and/or environmental change makes sense. We're lumping policy systems and environmental change together to differentiate them from programs, and there will be more on that later. So here is a very nice looking street. When thinking of policy systems and environmental change, one asks, how did that get to be that way? And it turns out that most of the built places, the built environments that we love to be in, got that way on purpose. This is an example from the city of Northampton. That image was from Northampton, Massachusetts. The city of Northampton's design guidelines. And I'm assuming you're all at your desk, but in case you can't read it, it says that the purpose of this chapter is to preserve and enhance pedestrian scale character. So you're allowed to put this kind of stuff in your design guidelines, and this is an example of a policy that literally changes the built environment. When you're thinking about making change, one way to approach making change is to deconstruct what is there by asking, how did it get that way? So this is my very abbreviated summary of how things that are built, the buildings, the streets, the sewer lines, how they get built. Somebody has an idea or identifies a need or is told by someone else to build something, a street or a building, and that person takes their knowledge of their training, and then they look at the existing local regulations and they build according to them. So in terms of facilitating policy systems and/or environmental change, you can intervene in the training of the people who are doing the building, which is not what we're talking about today, but it's good to keep in the back of your mind. And then alternatively, you can intervene by changing the existing regulations and/or facilitating new local regulations and practices that will affect the physical environment. And I would submit that a key difference between a program and policy systems and environmental change is that a program is making change one by one, whereas policy systems and environmental change is making change forever. That is, until someone changes the existing regulation that you just changed. But policy systems and environmental change produce a bigger bang for your buck. I mentioned that I was in the Peace Corps, and I imagine that many of you are familiar with the saying, give a person a fish, they eat for a day, but teach a person to fish, and they eat for a lifetime. Well, policy systems and environmental change is not exactly about teaching people to fish, but it does have lasting impacts. I did mention that I now live in Springfield, which is the home of Dr. Seuss. I know that with this image, I run the risk of the one thing that you remember from this presentation being green eggs and ham. But what I really want you to remember is the idea that policy systems and environmental change last longer than programs and can literally do whatever you can get approved. Because I imagine that many of you are from health backgrounds, I'm using the Haddon matrix as another way of illustrating the difference between programs and policy systems and environmental change. I was introduced to the Haddon matrix when I worked for the Wisconsin DOT on pedestrian and bicyclist safety, and I love the order of it. And of course, it works. You can prevent injury by intervening before, during, and after an event, and you can direct your interventions at the individual, at the equipment, and also at the physical, aka the built environment, at the social environment, and as I have added here, at the regulatory environment. So you can make cars safer, or you can teach drivers to be safe, or put in guardrails that keep drivers safe when they drive too fast. And you can also change the regulatory environment to improve safety. You can lower speed limits, and then you can go so far as to change the regulatory environment that directs how cars are built, mandating seatbelts, as Aaliyah pointed out, and airbags, and changing that equipment, which results in producing safer equipment forever. And those are the same kind of changes that you can make in your built environment. So here are some examples of built environment programs which are implemented piecemeal across the country, one by one. Programs that result in fish for a day. And then these are examples of built environment policies: complete streets, joint use agreements, design guidelines that result in fish for a lifetime. If we not only do programs and also do policy systems and environmental change, we can feed people for a lifetime. That's not really what I mean, but what I mean is we'll make lasting change. So if you want to change your community's policies that govern the built environment, you can choose between two different approaches: a complete regulatory overhaul or a complete zoning overhaul, looking at all the regulations that are affecting the built environment, or you can do it piecemeal, a little at a time. And I know I've differentiated between programs and policy systems and environmental change by pointing out that programs are a little at a time, whereas policy systems and environmental change is long-term and comprehensive. But now I'm also pointing out that policy and systems and environmental change does not have to be scary and overwhelming. You can actually implement it a little at a time. And in reality, as we all know, change is frightening, hard, and many times it makes sense to pursue policy systems and environmental change a little at a time. I can imagine that if we were together and I could see your faces, some of you would be wrinkling up your faces in frustration at my apparent oversimplification of the process of achieving policy systems or environmental change. Rest assured, I do know that it is hard and time-consuming. Here in Massachusetts, we have zoning regulations that require a 2/3 majority to change. And we have many towns with direct democracy, which means that every citizen of voting age gets to attend town meeting and vote yes or no on your proposed zoning changes. So yes, it is hard to change zoning. It's hard to change these kinds of land use regulations. But some policy changes are easier to implement, and regardless, just because it is hard, of course, that is not going to stop you. Because one of my charges is to help you to identify key components and strategies to incorporate policy systems and environmental change into your community initiatives, I wanted to help you understand who are the decision makers. So this is an overview of Massachusetts local government. But as I'm certain you all know, in Massachusetts at least, we have 351 cities and towns, and it depends from community to community where the change is happening. It's coming from different places in every community. And so, unfortunately, it's up to you to figure out where your leverage points are. And why we use the word leverage point is because with the right leverage point, you can move a boulder with a stick. And we're talking about community-wide change, which will result in a healthier built environment. One very popular built environment policy that is sweeping across the nation is complete streets policies. And this is an example of how the built environment can be changed with such a policy. In addition to policy changes, we talked about the systems and environmental change. And if you look at the Healthy Community Design Toolkit, Leveraging Positive Change, which is available from the Massachusetts Department of Public Health and also on our website, one example of an administrative policy that we recommend is to require a community health advocate to sit on your local development review committee. And this is done in West Springfield, and it integrates consideration of health into developments in the community from the beginning of the development process. Another example is that the Mass DOT has integrated the use of health impact assessments into major transportation projects, which is another example of an administrative policy that could be very beneficial to changing the built environment to promote health and well-being. So in addition to the ones that I've mentioned, the City of Springfield has recently adopted a community garden ordinance, which had the specific and deliberate goal of improving health by connecting people to healthy food. And you can locate this ordinance on the City of Springfield website. But again, I wanted to show you these examples in case you're not land use planners. You may not be aware that it's legal, it's okay for a municipality to put this kind of specific and direct language into their local regulations to direct what happens in their community. And this is Gardening the Community, a youth empowerment organization in Springfield that is taking advantage of the new ordinance to expand their community gardens. So I would be very happy to speak with anybody offline if you want to call me or email me, and I look forward to your questions. Thank you.
Thank you, Catherine, so much for sharing with us about healthy community design. Folks will be emailed the contact information of all of our presenters today, so that if you do have more specific questions or follow-up information, you will be able to do that. I would like to transition now to Arlene Goldstein. Arlene will be speaking about the Quincy model. So I don't want to take any time away from you. So Arlene, you can go ahead and dive right in.
Thank you for inviting me here today. I hope you find learning about what's happened in Quincy to be interesting and something that can help you in your work. Before we begin, I'd just like to give some background for folks who might not be familiar with some of the wording and some of the vocab within it. What are opioids? In the best of all possible worlds, they're prescribed for pain management. They're highly addictive. Here's the difference between an opiate and an opioid. Opiates come directly from the opium plant, and there's an orange shot of it on the side there. Opioids are constructed in laboratories in the usual pharmaceutical houses. They can obviously be legally prescribed, and no one wants to deny anyone medications that would stop intense pain. That's not what everything was about. It's about the misuse and abuse. The street drug heroin is an opiate. Here are some examples. The little asterisks next to the words are naturally derived from the opium poppy, as I mentioned in the previous slide. The other names down there, such as buprenorphine, these are the generics, the ones that are on the top, and the ones that are below are the trademarked names. So Suboxone is a trademarked name, which is also used in when people are in recovery. But there are some components to diversion, etc. But here are some of the others. Oxycodone, examples, OxyContin, Percocet, Percodan. So what is an overdose? That diagram, that illustration, represents a receptor on the brain. You imagine it like a cup. And as the cup is filled up with the substance, little by little, the pain goes away. Little by little, taking too much, if you're abusing, you get a high. When it begins to fill up and you overflow, you go into overdose. And what that does is it automatically stops the automatic breathing systems in your brain. Opioid death is lack of oxygen. I'm having trouble moving. So here's another component. What is nasal naloxone? Nasal naloxone is the medication that reverses an opioid overdose. It's a temporary medication. It's as you can see, you have the box that it comes in there, and the little tube with the red cap on it is the med itself, and it goes together, as you see on the right, in a nasal applicator with the medication on the bottom, and half is squirted up one side of the nose and half on the other when a person presents with overdose, which means that they are unconscious. So one of the things with nasal naloxone is it isn't enabling because number one, you have to be totally unconscious to be an overdose, and it's pretty hard to give yourself a medication if you're unconscious. It takes about 1 to 3 minutes to take effect, and it only lasts in the body about 1 to a couple hours, and then that's why it's recommended that people are transported to an ER. So setting the stage, why and how the work began. Here's the issue. It's an epidemic. More people die of opiate overdose than are killed in motor vehicle crashes. That is here in Massachusetts. And in the next slides, you're going to see that it's also, the CDC, the Center for Disease Control, has said the same thing. Leading cause of death in 2012. More deaths from opioid overdose than motor vehicle crashes. And you probably read in the paper or heard on the news how the governor declared a public health emergency in Massachusetts. That is the issue. So how did we get to policy change in Quincy? Collaboration, collaboration. There are a lot of moving parts. So as I move through, what I want you to understand is a lot of things were happening simultaneously to bring us to the magic moment when policy was actually instituted. So I'm going to start explaining the plates, and finally you'll see the plates come together. We have to go back to 2007 when the Massachusetts Department of Public Health Narcan pilot program began. And just as it says, the standing order was issued, but in 2007 there is no pilot site in Quincy. They are in Boston, they're in Cambridge. There was about 7 or 8 at that time. Now, here's another spinning plate. In 2000-2008, the grant, Mass Call 2, the Massachusetts Call for Action, Leadership, and Learning 2, there is no Learning 1, they called it that, but I'll be referring to it as Mass Call 2. And the purpose of that grant, for which I was program coordinator for the city of Quincy, was to address unintentional, fatal, and non-fatal opiate overdose. It had nothing to do with preventing people from getting started in the first place. This was to address the issues with folks who were already in the life. And why? Quincy applied because we ranked 7th in the state for opioid overdose. I'd also like to explain that Quincy is a South Shore community of about 92,000 folks, 30% of which the population is Asian, and 70% of which the population is Caucasian. Most of the reported use, opioid use, is within the Caucasian community. 2007, another spinning plate. This is very important. There is Mayor Thomas Koch. He was running for office in 2007, and he pledged to address this rising issue of opioid use and opioid overdose in the city. He wins the election, and he begins to come through with his promise to help us act on this issue. We applied for the grant. We received the grant. And what was interesting about Mass Call 2 was you just couldn't apply. Impact Quincy is a program of Bay State Community Services, which is a social service agency on the South Shore. You couldn't apply just through Bay State or through Impact Quincy. Any entity that applied for Mass Call 2 had to be connected to a town or city, some kind of municipal government. And so there was no hesitation from Mayor Koch because he was beginning to follow through on his campaign promises. Now, Impact Quincy is a substance abuse coalition who I worked for 6 years, up until a few months ago, but it was established in 1991. It is a very strong coalition in the city with a lot of involved partners. These are just some who happen to touch on Mass Call 2. Everything from Quincy Medical to QATV, which is the cable station, to corrections in Norfolk County, the Norfolk County DA, so on and so forth. But also notice A lot of parent and community member participation. Here, pulling out those same logos is the direct capacity that led to policy change. The City of Quincy, which is the upper left, I'll go counterclockwise, the Quincy Police, Bay State, which is the actual agency, Impact Quincy is a program of. The funding came out of PSEs and DPH, and then in the center of all this, we have our grassroots leaders, our parents, and our community members. Now I'm going to tell you the story of how this actually came. The Holler family has given me permission to use their name and their picture. Nancy and Steve Holler continue to be huge advocates for addressing this issue. This is what happened that fateful day in 2009. Brandon was from a fabulous middle-class home, had all the right pieces. He had his schooling, he did well in school, he was quite an athlete, he was set to go with scholarship on a baseball scholarship to a local college. But in 2009, and this is a word of warning, he started fishing around in the family medicine cabinet. And in that medicine cabinet, because Steve is a lobsterman and has back issues, he found OxyContin and began experimenting. And this is how his journey began. By 2009, he was a full-blown user. But as all loving families try to do, they supported their son, and Brandon came back to their home promising to go to treatment. While the family was downstairs, and this was an extended family, he had younger sisters and grandparents in the home. Their family's downstairs, Brandon is upstairs, they hear a big bang. Steve goes running upstairs, finds Brandon with a needle in his arm, unresponsive and blue. They called 911. Most communities have two types of ambulances, a basic life support ambulance, a BLS, and an ALS, an advanced life support. First, the BLS came. No naloxone, no Narcan. Then the police came because when you call 911, they come out automatically in Quincy. No naloxone. 10 minutes have gone by till finally the advanced life support is there. Now, if the family is around, you can imagine the chaos. They are seeing their loved one on a bathroom floor. It was, needless to say, traumatic. The third ambulance brings the advanced life support, brings multiple doses of naloxone. Brandon is revived by some miracle, no brain damage. He lives and is taken to an ER. The family being traumatized, then with other community members within Impact Quincy and others who were just working on the issue generally, request a meeting with Mayor Koch. They get it. And then Mayor Koch agrees to this, and at the same time with the spinning plate, because of them, of what had happened and everything that began and all the things that were talked about in Quincy, the first thing that happened was DPH allowed Bay State Community Services to be a site of a Narcan pilot site. So it wasn't until 2010, and even though 2007 was the start of this. And during that time, the Quincy Police Department was the only police department in the state to directly call DPH and say, we want to be a pilot program, we want to use this med. Here it is. This is the policy that was written by the Quincy Police and is there today and for the future. Obviously long-term, obviously sustainable. As of today, 307 individuals are alive. Now this is strictly since 2010 from the Quincy Police. This doesn't mean EMTs. This doesn't mean people administering by themselves. This or someone who is with a user who needs this. This is just the Quincy Police. This is Lieutenant Patrick Glynn, who I worked closely with and still do. This work, this policy work, training all the police and actually fire at this time were trained as well. 400 individuals were trained by Bay State Community Services. Now, that was a separate entity from Mass Call 2 because Mass Call 2 said you were not allowed to distribute naloxone. I was allowed to teach about it, but I could not give someone a kit. So a different person trained all of the Quincy and fire. And this work was recognized by the Office of National Drug Control Policy and is now referred to by Commissioner Botticelli as the Quincy model. Lessons learned. The biggest challenge here, I must say that everyone who collaborated on this, there were no egos. Everyone played in the sandbox equally. The only issue that arose was the Quincy fire because of union issues. We, held back on having the trucks carry. But now they're on board. What do you need? You need your grassroots leaders in your communities. If you have an important policy change, you need grassroots, and those are the people who are directly impacted. We had our parents whose adult children were faced with this terrible disease. Here are other examples of who could act as an advocacy target, a grassroots leader. You can see the list there. And then we have what are referred to as grass tops leaders. This was the city of Quincy coming from the mayor of Quincy, who stood by his pledge to do something about this, who listened to his community members, who stepped out. This was the first time this was done anywhere in the country. This is why the Quincy model is held up, because no one really worked on this issue. No one, you said police carrying naloxone, and people just looked at you like, what are you talking about? But it worked. Initially, even the police, when you went to roll call, they weren't believers. But they were believers when the first policeman came back and said, I saved somebody today. And this is what I'm here for, to protect and serve. So if you have any questions, please contact me. I'd be happy to answer them for you. Thanks so much.
Thank you so much, Arlene. We do now have a few moments to be able to answer some of the questions that you all have been typing in. Just to recap, as folks may have other questions that they want to type in now, we talked about what the policy systems and environmental changes are. We talked about, Arlene gave a great example about what the catalysts were for those policy changes to take place in Quincy, including having data, having a political environment that was favorable towards the change, involving coalition members, including many different organizations and, of course, residents. Kathleen also talked about involving residents and many different entities in terms of making changes in smoke-free housing. And Catherine also talked about, the fact that policy change is possible. It doesn't have to be daunting. There are incremental policy changes that you can make, and you can actually literally change documents and make changes to policies. And she gave great examples of policy changes that are literally listed on the books and showed us pictures of the actual effects in communities. So I do want to just thank all of our speakers and presenters here today for sharing your stories. We're going to go ahead and start with some of the questions. So for Arlene, who is allowed to carry Narcan right now?
Anyone. Any, let's call you civilians versus police. Anyone can obtain a naloxone kit as long as you're 18 years and older. If you need something for someone younger, an adult can purchase it for them. Naloxone, there, if you go to the DPH websites or you have trouble finding it, I can let you know how to get it. It's, you can easily see where all the sites are. They're also distributed at Learn to Cope meetings, which are throughout the state, which is a support group for parents. I hope that answered your question.
Thank you. A more general question for all of our speakers. Do any of you have any practical resources that can be given as to how to write policy? And you can speak specifically to your area of expertise, or if you know of any other general resources that you could share with those who are listening.
Sure, I can jump in. This is Kathleen. In terms of smoke-free housing, we have sample policies which we provide to all of the landlords that are making a decision to go smoke-free. And so we have those available on an online website, which I could share with Aaliyah. But from a more general perspective, I would recommend that you work, if you're working at the city and town, whatever level you're working with, the decision maker will most likely have a process that they have in place for any adoption of policy. And so working directly with those decision makers, they often consult with their lawyers around exact language. So even when we're adopting smoke-free housing policies, while we provide recommended language, often words are tweaked here and there by the lawyers of working with the actual landlords.
And I know, this is Arlene speaking, strictly with the opioid issue. I've shared policies on cities and towns having med return kiosks in the police stations, sharing the Quincy police policy, all the policies, even like for take-back days, prescription and over-the-counter med take-back days. Most folks, once they pass the policies, I've found are pretty open to sharing all different kinds of documents, and you can compare language and work it out with the group that you're working with to create what you want.
And as far as the built environment policies, the Pioneer Valley Planning Commission, we have a sustainability toolkit on our website. Well, I'm not sure if it's right up yet. We're just finishing it up, but it has a lot of model bylaws with appropriate language requiring sidewalks and new subdivisions, bicycle parking, complete streets policies, all that kind of thing. And we serve, obviously our website is open to everybody. There are regional planning agencies throughout Massachusetts and indeed around the country. And you can just call your regional planning agency. You can certainly call me, and we can send you the examples of the kinds of bylaws or ordinances that you're looking for.
Catherine, do you mind just sharing with us what your website is?
It's PVPC, as in Pioneer Valley Planning Commission.org.
And again, to everyone who is a part of this webinar, in the follow-up emails that you will get, which will include both the slides, the recording, we will also have these lists of resources that we've been talking about here today. Do we have any other questions? Well, if we have no other questions, I do just want to end this webinar by saying thank you again to everyone who was able to participate with us. We know we had a time delay, so we thank you for bearing with us through our technical difficulties. Again, thank you to all of our speakers. Thank you for your flexibility and for sharing your expertise. Thank you, everyone.